Hello, this is the oral medicine presentation for Group D, and we've got a case study here involving a patient complaining of oral facial pain. So to start things off, it's a female patient in her mid-60s, and the main reason for her visit was that she's experiencing pain in the right side of her jaw. In order to assess the history of the complaint, a pain history assessment was performed. It was found that the pain has been ongoing for the past 2 years. It is exacerbated by touch, cold water, and wind. She described the pain as electric shocks on the right side of her face, with a pain scale of 12 out of 10. The patient found that gabapentin 1400 mg per day slightly reduced her pain experience. And on top of that, she was also taking paracetamol, ibuprofen, and codeine. In terms of medical history, she was allergic to sulfur drugs, but she did not go in depth about what kind of reaction occurs with taking the medication. She has no known cardiovascular diseases or any respiratory problems. She does, however, have celiac disease, which is hypersensitivity to gluten, so she cannot eat certain foods containing wheat, barley, and oats. In terms of medication, she's taking the aforementioned pain relievers for the orofacial pain, as well as docusate sodium for constipation. She has also mentioned that she smokes 10 cigarettes per day and rarely consumes any alcohol. Her facial profile appeared to be symmetrical during the extraoral exam. There were no visible swellings or scars on the face, and the facial nerve function appeared to be normal. Mouth opening was within the normal range at 3 fingers wide, and there was no deviation on jaw opening. There was no muscle tenderness from any of the muscles of mastication on palpation. The TMJ also appeared normal. Finally, lymph nodes were palpable, but no abnormalities or pain was found. During lateral excursive movements of the jaw, it was also found that the patient was unable to excurse to the right as much as to the left. Intraoral examination showed that the soft tissues appear healthy. Mrs. HM's tongue also appeared normal, with a cream white fissure on the dorsum of the tongue. Her soft palate and pharynx also appeared normal. The salivary glands were found to be soft and no abnormalities associated with them. In terms of her dentition, she has a class 2 occlusion and is partially dentate, missing the posterior maxillary teeth and mandibular second molars. For her remaining teeth, there were signs of bruxism along with the presence of heavily restored mandibular posterior teeth with numerous amalgam restorations. Looking at the OPG, the TMJ appeared to have symmetrical condylar heads that are anteriorly positioned to the glenoid fossa. On the left-hand side, the space between condylar head and the articular eminence is very small, which indicates thinning down of the condylar disc or potential bone-to-bone contact between the condyle and the maxilla. No abnormalities were detected on the right-hand side. The maxillary sinuses are symmetrical and pneumatized. The nasal cavity also appeared symmetrical. Moving on to the dentition, what we see on the OPG correlates directly with the intraoral examination, with heavily restored dentition and multiple missing teeth. What we can also see is that there is generalized horizontal bone loss up to the apical thirds of the lower third molars. It is also worth mentioning that the lower third molars appear to be drifting mesially across the edentulous space. After the initial examination, a provisional problem list can be formulated and differential diagnoses may be made. Special tests can help with identifying or ruling out some of the differential diagnoses. The tests required in this case include intraoral tests, such as sensibility testing, palpation, probing, the use of a frac finder, and radiographs such as periapicals in order to identify potential dental abnormalities. In most instances, it is useful to request an OPG that is updated to identify potential pathology associated with the maxilla and the mandible. In this case, there is a possibility of TMJ dysfunction. Therefore, it is important to perform an accurate physical examination of the joint, and depending on what the clinician suspects as the cause, he or she may request a blood test that include a white blood cell count in order to rule out lupus, rheumatoid arthritis, or gout, which are known to be associated with TMJ dysfunction. Lastly, for the most accurate examination of the TMJ, a CT scan can provide detailed images of the bones involved in the joint, and MRIs can reveal problems with the articular disc. Because of the fact that Mrs. HM presented with chronic orofacial pain, it is worthwhile to perform a neurological exam to test motor, sensory, and reflexes associated with the head and neck. Information regarding the patient's pain history is important to identify the areas of concern, particularly when neurological pathology is suspected, in order to narrow down the nerve involved. In the case of trigeminal neuralgia, special tests for the trigeminal nerve, including all divisions of ophthalmic, maxillary, and mandibular divisions, should be performed. These include, but are not limited to, functions of the muscles of mastication and sensation of fine touch, pain, and temperature to the head. Preoperative MRI can be used to rule out any pathological etiologies such as tumors or demyelinating disease, and to identify the presence of any vascular compression at the root entry zone of the nerve. For patients complaining of unilateral facial pain, the number of differential diagnoses is numerous. Our differential diagnoses for this case include trigeminal neuralgia, odontogenic or dental pain. These ranges from dentine hypersensitivity, pulpitis, cracked tooth syndrome, periapical periodontitis, and periodontal abscess. Temporal mandibular joint pain dysfunction, facial trauma or tumors, post-zoster neuralgia, PDAP or persistent dental alveolar pain disorder, and lastly, any other idiopathic facial pain. On the basis of the history and examination, without the use of special tests, the most likely diagnosis in this case is trigeminal neuralgia. This is a chronic pain disorder that affects the trigeminal nerve. It is the most frequently diagnosed form of facial pain, with a prevalence of 4 per 100,000 in the general public. The disease has three main variants as described by the Revised International Classification of Headache Disorders. The first classification is the classical trigeminal neuralgia caused by microvascular compression of trigeminal nerve root that causes demyelination of the nerve. The second variant is that of trigeminal neuralgia with concomitant persistent facial pain. And the last variant is symptomatic trigeminal neuralgia caused by non-vascular structural lesions. The typical form of the illness is often described by episodes of sharp, shooting, electric shock-like pain limited to distribution of one or more divisions of the trigeminal nerve. Episodes of intense pain occur paroxysmally, and it occurs in cycle with remissions lasting months or even years, and is triggered by touch to the face or even air currents. Trigeminal neuralgia is often misdiagnosed and can be very difficult to treat. Treatment options include medication and surgery. The first-line treatment is the use of anticonvulsant drugs such as carbamazepine, which stabilizes the inactivated sodium channels, lowering the cellular excitability of the nerve. Second-line medications include baclofen, gabapentin, and pregabalin. Gabapentin is suggested to be the most promising drug. If medical therapy fails to improve quality of life, surgical treatment is indicated, which includes either microvascular decompression or ablative procedures. Microvascular decompression has been widely used based on the theory that vascular compression of the trigeminal nerve is responsible for trigeminal neuralgia. Craniotomy is performed to separate the blood vessels from the trigeminal nerve. A recent retrospective review of patients with trigeminal neuralgia who had undergone MVD showed that a high proportion of patients, about 71%, reported complete pain relief 10 years after surgery. Mortality rate for MVD ranges from 0.2% to 0.5%. There is a 4% incidence of postoperative morbidity such as cerebrospinal fluid leak, infarct, or hematoma formation. Gamma knife surgery is an ablative technique that provides an alternative to microvascular decompression for patients with contraindications precluding surgery. Pain relief obtained from GKS is delayed, but usually occurs about 2 weeks later. Initial good pain relief can be achieved in about 80% of patients. However, there is a risk of recurrence after 1 year. As with all surgical procedures, it is important to explain to the patient the associated risks and the potential for relapse prior to commencement of surgery. Lastly, due to the chronic nature of the illness, psychological and social support is of great importance in order to provide the best care available for the patients. Thank you for listening.